In 2001, John Coyce described 5 pretreatment diagnostic keys. Those 5 diagnostic keys are tooth position, free gingival margin position, gingival form, biotype, tooth shape, and osseous crest. If we start with tooth position, free gingival margin position, the tooth that is in lingual version or has free gingival margin position that is coronal to the contralateral tooth is deemed a low-risk candidate for tooth replacement. A tooth that is in buccal version or has a more apical free gingival margin compared to the contralateral tooth is considered a high-risk candidate for tooth replacement. If we look at these 2 cases here, you can see that tooth number 9 on the left, which would require replacement, the free gingival margin is apical to the contralateral tooth, and that tooth would be a high risk of an aesthetic result. On the right side, tooth number 8, the free gingival margin is more coronal to the contralateral tooth, and that is a lower risk to aesthetic tooth replacement. So what do we do if we have a tooth that has a free gingival margin that is positioned apically? We must think about developing the soft tissue or changing the biology prior to extraction to try to change the risk from high risk to low risk. If we were to extract this tooth in its present state, we can end up with a scenario that will result in a catastrophic replacement, an unaesthetic result, where the free gingival margin is significantly apical to the contralateral tooth. So what we need to do is improve the biology prior to extraction. We need to engage our orthodontic colleagues or ourselves and change that free gingival margin prior to extracting that tooth. As in this case, where we used light continuous orthodontic force to extrude the tooth, bring the soft tissue and bone down so that now you can see the free gingival margin is equigingival to the contralateral tooth. But we will continue to erupt this tooth to make this scenario more of a low-risk candidate. As you can see here, the free gingival margin position now is far coronal to the contralateral tooth. In fact, if we compare it to where we started, the outcome is significant. Then we can go ahead and extract the tooth, place our dental implant, place our screw-retained provisional, develop our soft tissue profile, develop our contours, and provide an aesthetic tooth replacement for our patient. So that our end result will have a free gingival margin that is equigingival to the contralateral tooth, from where we started to where we ended. And at 42 months, you can see we still have a pretty aesthetic result.